Thank y'all for joining us tonight. I'm Hannah Collins. We're here with Dr. Cates discussing Athlete's Guide to Prevention and Treatment. I'm going to go ahead and introduce him and then give him the floor. Dr. Cates is originally from Tennessee. He attended Truman State University on a full athletic scholarship where he was named academic All-American and All-Conference performer as a defensive end on the varsity football team. After graduation, he attended medical school at the University of Tennessee, where he was inducted into the Alpha Omega Alpha National Medical Honor Society. Upon completion of medical school, Dr. Cates continued his orthopedic training at Atlanta Medical Center. Following the competition of residency, Dr. Cates continued his training at the Atlanta Sports Medicine and Cartilage Reconstruction Fellowship. During this time, he was able to focus on arthroscopic techniques, cartilage reconstruction, and less invasive surgery. Dr. Cates acted as an associate team physician to the Atlanta Falcons and Atlanta Thrashers, gaining valuable experience in the care of elite athletes. Dr. Cates is now an orthopedic surgeon with the Carrollton Orthopedic Clinic, where he takes time to listen to patients and focuses on the individualized approach to patient care. Dr. Cates' main priority is to focus on resolving patients' problems using the least invasive method. Dr. Cates now resides in Carrollton with his wife, Bailey, and their 2 children. Dr. Cates, whenever you're ready.
Yes, well, I just wanted to thank you so much for joining me tonight. We're going to talk about a lot of different topics and cover a lot of different things. I just also wanted to say I appreciate this community. It's been a wonderful community for me and my family, and I appreciate you taking the time away from your schedules to be here tonight. First thing I really wanted to talk about was sports injuries in general. These are a wide range of injuries. They range anywhere from fractures to concussions to dislocations. More common injuries you'll hear about are ACL injuries and meniscal injuries. We'll also have cognitive injuries, which includes concussions, and we'll go through all of this tonight. I wanted to say that don't worry if you haven't been playing professional athletics. This is really a talk more about general sports and athletic injuries. And I feel like anybody that is involved in heavy activities like running, like soccer, or even walking and hiking are considered an athlete in my mind. And I take care of so many range of athletes that it really doesn't matter what you do, just that you're out there enjoying life. I'm going to start with talk about concussions and cognitive decline. One of the things we found as sports medicine physicians over the last decade really is that there's a huge consequence to concussions. Back when I was playing football in college, really if you had a concussion, the coach would put you back in immediately and just tell you kind of rub some dirt on it and get back out there. But what we found, and really this came to light through the NFL, is that there's serious consequences with concussions. One of the things that can happen is you can actually develop dementia later in life from concussions. So now we're very careful, and it's a very important part of my practice to properly manage concussions. We've come a long way in the management of concussions. One of the things we started doing is actually testing people prior to the season. That way, if they do have a head injury, then we can have a baseline study. This is called impact testing, and it's been a great tool to help us determine when a player can get back in the game. Concussions really come in 3 grades. The first grade is mild, where there's no loss of consciousness, lasts less than 15 seconds, where symptoms resolve very quickly. A second grade concussion is a moderate injury, and there's no loss of consciousness, but the symptoms last for greater than 15 minutes. And then a grade 3 concussion is where a player is basically is down on the field, and there's a loss of consciousness for any period of time whatsoever. Now, any of those concussions, we're going to pull that player out of the game and put them through what's called a concussion protocol. Concussion protocols have really evolved over the last decade, where now we have some really precise testing to be able to determine when it's safe to return a player to the game. This is all extremely important, and the NFL has recognized this. In fact, they have now spotters that are placed around the stadium to watch players to see if there's any abnormal activity after plays, particularly after big hits, and they can pull them from the game. And they also have a neurosurgeon that's independent of the team, so they can help determine when a player is safe or if he needs to be pulled. during the protocol, what happens is we take the player to the side and run them through a variety of tests to make sure that they're safe. Typically, if there's any concern that they've had a concussion, we'll just simply take that player out of the game, take his helmet, and then we'll start working on the testing during the week. There's several phases that they have to go through in order to return to play. One is that they have to have no symptoms, no headaches, no sleeplessness, no memory difficulties. Once they pass through that phase, we start exercising the patient. Once they get to a level of exercise, we'll retest them, make sure that they're continuing to improve from their neurocognitive standpoint. And then as long as they continue to improve and stay symptom-free, we can let them go back and play. Some of the important things to know about concussions, we talked a little bit about the causes, or that it can cause dementia later in life. It can also cause some mental disturbances. There was a famous situation where one of the players in the NFL, a player named Junior Seau, who's an extraordinary linebacker, committed suicide very young. And it was found out later that he had many concussions. And when they studied his brain, they found some very permanent and very severe changes in the actual structure of his brain. So we're continuing to learn, but it's a very important part of being a sports medicine doctor. One of the things that we're going to talk about next is arthritis. Arthritis is one of the primary things I treat in the office. It's one of the most damaging things really to the quality of life of many people. I focus on knee arthritis. My partners focus on arthritis in the hip and other areas. But the next thing we're going to speak about is arthritis. What is it, and how do we address these problems? Arthritis essentially is a problem with cartilage. And if you look at this model, you'll see that there's several parts to the knee. One, here's the kneecap, also known as the patella. The cartilage, and this is important, is the white lining that surrounds the joint. You have cartilage on all surfaces, and that's what gives your joint the ability to slide and move freely without difficulty. The next part that I'd like to show you is these are the ligaments. This is the medial collateral ligament. This is the lateral collateral ligament. And these are the meniscus, both an inside and outside meniscus. And in general, what we do is we bring the knee into 3 different parts so we can help to identify the problem. There's the inside part of the knee called the medial aspect of the knee. There's the outside part of the knee, which is here called the lateral aspect, and then the patellofemoral joint. Now, when you have an injury to the cartilage, these changes occur. You'll see areas where the cartilage is no longer present, and really underneath that cartilage is bone, and cartilage acts as a protector to the bone. It's a specialized tissue in that it's firm, but yet is very, very slick. And so when you lose that slickness, you start to have problems with bone inflammation. You start to have the sensation of popping and grinding. And then the other thing that happens is cartilage injuries become more advanced as you start to develop arthritis. Arthritis really is where the whole joint or a portion of the joint breaks down, and it's a global phenomenon, meaning that the entire joint is typically involved, although it is worse in some areas in some people. So how do we take care of this problems? Well, initially, we want to find out how bad the problem is, where is the location of the cartilage injury. So a lot of times if you'll come to see me, the first thing I'm going to do is talk to you about your pain, talk to you about location of pain, talk to you about your symptoms. And then once we get a great history, then we'll determine what the next step is. I initially usually focus on getting the inflammation down on the knee. I love to treat people non-operatively, so a lot of times we'll do things like anti-inflammatory injections, we'll place you on anti-inflammatories, and take steps such as physical therapy to regain motion and strengthen the joint. And if these don't work, then I'll go ahead and obtain an MRI. An MRI, of course, is a magnetic resonance imaging. And what it does is it looks at the cartilage, looks at the other structures, such as the menisci and ligaments, and gives us great information so we know exactly what we're dealing with, so we know how to treat you properly. I wanted to talk to you next about other options. Let's say that the initial steps to try to treat your pain aren't effective. So what I'll do then is determine the next step, and sometimes that's surgery. Surgical intervention consists of many different things depending upon location of cartilage injury and also age and other things. But when someone is young, what I like to do, or young even up to the age of 50, sometimes 55, is try to get that cartilage to heal. And these areas that you see on the screen that are damaged, what I can do is I can actually take cartilage from around the site of damage. Sometimes I'll take cartilage from the very edge of the knee, and we'll turn it into a cartilage graft. The other constituent of that graft is blood, and I get blood from my patients during surgery while they're asleep. I'll take the healing cells from the blood, combine it with some of their cartilage, sometimes also with a little donor cartilage, and utilizing arthroscopic technique, which is a small camera, I can place the cartilage back into the knee and get it to heal. And that's a common procedure. I've done about 400 of those in my career and extremely effective in most people. Now, if the damage is more extensive and it looks more arthritic, then sometimes we consider knee replacement. There's a couple kinds of different knee replacements. One's a partial knee replacement. I got some models to show you. So in this model, what I'd like to show you is that there's the inside cartilage, outside cartilage, and here is the damaged cartilage in the central part of the knee. This is where the kneecap resides and where the knee glides back and forth as you move and bend. So if somebody had a knee that was, the cartilage was good here and good here, but damaged here, then what I'll do in that situation is simply replace the damaged cartilage with a device like this. And once I get the metallic surface into place, I'll put a little plastic button on the kneecap. So we keep your kneecap, but just provide a new surface. So that way the gliding is restored. Now, if the damage is more extensive, let's say all over the knee, then we'll consider a knee replacement. And this is a model I have of damaged cartilage. So if the damage is here and all throughout the knee, what I can do is actually shave off the very edge, the very surface. One thing that's important to remember in a knee replacement, we really don't replace the knee, we're actually resurfacing the knee. And what I'll do is place a plastic and metal component to give a new surface, a new gliding surface. It basically replaces the cartilage, and then put a metallic surface on the upper bone called the femur. Once those are in place, the knee begins to glide smoothly again. We've come a long way with knee replacements. I'm even doing some custom knee replacements where we get a CT scan of the knee, and then we replace or we provide a replacement that's made only for you. The next thing I'd like to talk about are signs of an injury. I get a lot of questions from people that ask me, well, what should I do if I have a swollen ankle after a sports injury? Should I go to the emergency room? Should I call to make an appointment? Should I just rest and see how it does? I think just a few little pointers. I think that if you can bear weight, then you can wait and not go to the emergency room. If it's during office hours, we have a very open door policy, so you can just call and make an appointment, and we'll get you in the same day or at the very least the next day. If there's trouble bearing weight or the pain's uncontrolled or you see deformity, then the best move at that point is to go to the emergency room, get x-rayed for potential fracture. But we like to see people in the office when at all possible. Emergency rooms are very expensive and a lot of times a longer wait. So we love to see patients that get hurt acutely and oftentimes in the same day. The next portion of my talk will focus on treatment plans. I think it's extremely important when I meet a patient to determine what's the right treatment plan for that individual patient. A problem such as a meniscal tear in one patient may be very different from a meniscal tear in another patient, depending upon age, activity levels, etc. So when I meet a patient, I want to determine, A, what's their level of activity? What are their goals? Are they trying to return to normal walking, or are they trying to return to athletics? And that plays a great role in terms of my decision making. But when a patient comes in and I meet the patient, I ultimately want to develop the right plan for them, which could include physical therapy, sometimes braces and splints, and sometimes surgical treatment, but we always like to focus on non-operative treatment first. There's also a future possible treatment that will focus more on the genetics of a patient. Once we can identify genetic markers that may determine whether they're more prone to develop arthritis, and we can actually start to tailor treatments based on their genetics. We do not have that clinical ability now, but it's certainly out there, particularly in cancer treatments, and that's an exciting thing that we may see within the next decade. We talked a little bit about surgical options. Arthroscopic surgery is something that's near and dear to me. It's something I do every week, but it's a beautiful procedure in that it's minimally invasive, and we're utilizing a tiny camera to go into the knee or the shoulder, whatever joint's involved, and repair the joint. And also cartilage reconstruction. We talked about that a bit earlier. That's something that's come a long, long way in the last decade. When I was training as a resident and a fellow, all we had were bigger open procedures where we had to open the whole knee, make incisions. Now we can do almost any or any cartilage procedure arthroscopically. So there's been a tremendous advancements. I think it's revolutionary, really, what's happened with cartilage restoration in the last 10 years. I remember when I was a child, my father had a knee injury that just kept getting worse. And I remember talking to him, and he told me that, well, cartilage, once it's damaged, it will not heal. But that's changed, and that's something we can actually get to heal now. Another really great advancement has been outpatient knee replacement and hip replacement. A year ago, I probably did 10%, 20% outpatient knees where people go in, have their surgery, and go home the same day. Now I'm probably 90% outpatient, and patients have done extremely well healing in their own environment. That means you don't have to stay in the hospital. When I was a resident, you probably had anywhere from a 3 to 5 day hospital stay after a knee replacement. Now most people go home. And at first I was a little hesitant, but when I've seen the results, I'm excited about that, and we'll continue to develop an improved program over time. Physical therapy is an important part of what I do. I work very, very closely with the local physical therapists, of which I believe we have great therapists in this area. There's lots of things they can do that can bring effective relief to pain and inflammation. One of the really neat things that's come out within the last 5 years is a technique called dry needling, where they actually use tiny little needles to stimulate muscle tension. And once the muscle is stimulated, it can release that tension and provide great pain relief. It's really been good in treating back pain and other kinds of problems. It's different from acupuncture, and that acupuncture is more of an Eastern philosophy. We actually do some acupuncture at our office, but dry needling focuses on really the primary spot of pain and goes right after it. Next thing I'd like to talk about is how your body changes. As you get into your 40s, really there's several things that happen. Your ligaments, they're not quite as elastic. Your skin's not as elastic. An injury occurs more frequently because your body just doesn't handle impact as well. And I see lots of patients that are my age, people that were athletes, former athletes, and it's really important to understand that your body changes. So as you're getting into your 40s, it's important to know that I want you to keep exercising. I want you to keep enjoying the outdoors, but do it in a little bit less impactful way. Things like cycling are really good, swimming's really good. But you do actually have some changes within the joints. Your knee and the cartilage within the knee actually dry some, so it's not as spongy and doesn't accept impact as well. A little bit of talk about exercise. Cycling is a great exercise because it doesn't have impact, and as your knee moves during a cycling event, the fluid in the knee moves and also bathes the knee in nutrients, and that's really, really helpful. So in a lot of patients with knee problems, patients that have had total knee replacements. In fact, I've been getting bikes for my patients that have had total knee replacements that are specialized to help restore the motion in the knee after that surgery. But when you're exercising over 40, you really got to be smart about it. Running, most people, it's not an ideal exercise because of the heavy impact as you load the knee during running. And also, you just got to make good decisions. Lifting things that you did when you were young can lead to things like rotator cuff tears if you're lifting something heavy. So you got to be careful and you got to be smart. And I see a lot of patients. I had a gentleman just last week when I was on call. He was a fairly young man, he's 43, but he had jumped down off about a 5-foot height. And while if he was a child, he probably would maybe get a sprain or some minor injury or maybe sting for a little bit. In this case, he had a very, very severe fracture that required surgery. So just be smart about your surroundings. Probably the best part of my job is seeing people return to the level of activity that they were at before they were injured or before they developed the severe arthritis. And so it brings me great joy, and I love to watch players that I've done an ACL reconstruction on return to their sport. I've seen many of my patients play in games and gymnastics and other things, and that's an extraordinary thing, and that's why I love this job so much. But I also love just seeing patients get out of pain. I mean, that's what really brings the joy to me and makes this job so wonderful. things like total knee replacement. See a patient that had severe arthritis, that couldn't walk, couldn't enjoy their grandchildren, be back and enjoying their family again, walking without pain. That's an extraordinary thing. Prevention's so critical, and we want to keep our bodies in shape. So somebody like myself who has a practice and can't always go to the gym, I got elliptical in my house. It's really, really important just to keep me moving. I think motion is key. Motion is life. And so I want you to all encourage you all to be out and doing things that keep the blood flowing, get the muscles strong, and that'll help prevent injury. It became so important in sports to start stretching appropriately, and I think that carries over into our adult life. We need to be good stretchers, and that can really prevent a lot of troubles, particularly as it relates to the back. So always be warmed up prior to getting out and doing any exercise, and that'll help prevent injuries. I just wanted to tell you all, thank you so much for listening to the talk I gave tonight, and it's been a great pleasure to be here. It's been a great pleasure being part of this community, and I look forward to meeting you all soon.
Dr. Cates, we'll go into questions that you had come through and discussing stretching. You actually had one ask about how to stretch your patellar tendon correctly.
Patellar?
Yep.
Oh, yeah. So that's an easy one. The quadricep stretch is the best way to stretch your patellar tendon, and that's really the simple stretch. You see where you basically take your foot and pull it behind you, and that stretches that quadricep, which is your thigh muscle. Now, the thigh muscle attaches to the kneecap, and the kneecap attaches to the lower bone, the tibia. So by stretching your quadricep muscle, you're actually stretching your patellar tendon. Patellar tendonitis is really common, so that's a great question, and that's the best way to stretch.
Okay, and another one was, how long does it take to recover from a pulled groin?
The groin injury is a tough one. Minor injuries resolve in a week or two, but groin injuries are notorious for becoming chronic, meaning that they'll be re-aggravated. So it depends on severity. I tell patients that when you're pain-free or when you have minimal pain, then you can return to sports or athletics. But key on groin injuries is to be a really good stretcher and warm up so that you prevent that injury.
Okay, and another one of your attendees also asked how you've torn your ACL.
So an ACL tear is really three things that happen. It's typically a non-contact injury, so history is important. That means that it's not that anybody struck you. Typically, it's a player or athlete running down the field. They cut to make a movement. And the second thing in an ACL injury, they'll feel a pop and perceive a pop. And that's the second key component to diagnose an ACL injury. And the third thing is that your knee typically will fill very quickly with blood, usually within 24 hours. So you'll get a big swollen knee after that occurrence.
All right. Well, that was all for the questions, but we are thankful that you joined us tonight.
Thank you very much.
And thank you all for joining us as well. Please continue to check out our classes on tanner.org/classes and events for other informative topics that we have coming up. And I hope you all have a great evening.